Hi class, in this final recording for this chapter we're going to focus on fluid replacement therapy and the implications of. As we look at fluid replacement therapy, it's how we restore the amount of fluid in our bodies and maintain the proper osmotic potential of different fluid cavities within our bodies. So we need to have the right fluid volumes, composition of the ions, and distribution of those ions, or we could have some big problems in our bodies. The best way to restore fluids in our bodies is just to drink it. So we take a drink. But we could also have intravenous techniques as well. As we look at fluid replacement therapy, it's kind of a tongue twister right there. We do this in order to replenish the overall amount of water in our bodies, to restore blood pressure balances, to move fluid from one compartment to another, or to maintain the correct electrolyte composition of our bodies. So, drinking water, very simple, very effective. It doesn't replace electrolytes though, although candidly most Americans don't struggle with an inappropriate amount of electrolytes. It's the water that we typically are going to lack. Dehydration is a much bigger problem than lack of electrolytes. However, if you're working with somebody who can't take fluids by mouth, there are different ways to get water into their body, even if they're unconscious. You can give them a water enema. So you can put a tube into their colon and give them water via their anus. One of the notable things about this enema approach is, let's say you're in a situation where you really need some water, but the only thing that you have available is swampy brackish water or water with high bacterial concentrations. You can consume water with high bacterial concentrations via the enema route and not worry about having food poisoning or having the nasty side effects that you normally get if you just drank the water, although it's still not preferred. I don't know anybody who likes that. We also can have the parenteral routes. So these parenteral routes, when we think of enter, think of digestive system. These are routes outside of the digestive system. And they are going to be ways that we can get fluid into the body other than using the digestive tract. Intravenous is by far the most common. We also could have a subcutaneous route where we inject the fluid into the adipose tissue as opposed to into the venous side of the circulatory system. We can inject the fluid into the muscular tissue, or one that gives me the heebie-jeebies is interosseous. You can inject the fluid into the spongy bone tissue of the bones. The preferred interosseous method is to palpate the tibia, find the tibial tuberosity, and then 2 finger lengths below or inferior distal to the tibial tuberosity, take a heavy gauge needle and stab it into their tibia and inject the fluid into the hollow portion of the tibia. The reason you go 2 finger lengths beneath, or I should say distal to, the tibial tuberosity is you want to make sure that you don't hit the individual's growth epiphyseal line or epiphyseal plate. As we do this fluid replacement therapy, one of the most common fluids administered is sodium chloride solutions or saline solutions. And when we give somebody a saline solution, we want that solution to be isotonic. When we say isotonic, we mean that we don't want it to pull liquid into the red blood cells or add liquid to the red blood cells. We want there to be no net change to the red blood cells volume. So we need it to be isotonic, which is calculated out to be 0.9% sodium chloride. As we give somebody this saline solution, it can raise the blood volume and not alter the osmolarity of their cells or their bloodstream. And if somebody needs very large amounts of this, the saline will start to escape the blood and enter the interstitial fluid compartments. And if that happens, occasionally we can have hypernatremia, too much sodium, or hypochloremia, too much chlorine. That's rather rare though, to give somebody that much saline. As we look at this fluid replacement therapy to correct pH imbalances, to treat acidosis, we give somebody Ringer's lactate. To treat alkalosis, we give that individual potassium chloride to treat an alkalosis situation. As we look at the volume of our plasma, we also can just give somebody a plasma volume expander, something that's going to cause the volume of their plasma to go up, but not necessarily influence the amount of liquid in their red blood cells. As we look at hypertonic solutions, or colloids that we add, the thing that we struggle with these solutions is we want them to draw water into the blood plasma, but not necessarily draw water out of the red blood cells. So it's tough to find something that actually works really well in these situations. We have found, though, that if we give somebody an albumin plasma protein combo, a dextran solution, or a hetastarc solution, these are solutions that we can inject into their blood plasma and cause more water to get drawn into the blood plasma. And this will cause water to get drawn out of the body tissues, the swollen cells of their body, but still keep their erythrocytes at the appropriate volume. And as we draw more and more water out of their intracellular compartments, the tissues of their bodies, that water is pulled into the bloodstream, and ultimately we have an increase in blood pressure, and then we would have an increase in the rate of urination or urine production in response to that increase in blood pressure. When we work with individuals who cannot eat and we need to give them some calories, we give them a 5% glucose solution. And this 5% glucose solution is significant because it means that they don't have to go through as much gluconeogenesis. They don't have to turn as many of their proteins into glucose or carbohydrate byproducts for the nervous tissue to consume. It has a very protein-sparing effect, reducing the amount of protein they lose. If somebody is fasting and just not eating anything at all, they can lose 70 to 85 grams of protein mass per day when they go through gluconeogenesis. But by having a small amount of carbohydrates, they can reduce the amount of protein that they lose by approximately half. Speaking candidly, I experienced this as a freshman in high school when I was cutting weight for wrestling, and I had to pull about 40 pounds in 1 month. It was not fun, but I made it happen. But the downside was that I lost a lot of my skeletal muscle mass in the process of cutting weight that aggressively. And I remember my sophomore year of wrestling, I was much smarter and made sure to eat just a little bit of bread every single day so I didn't lose as much skeletal muscle. If somebody has renal insufficiency, they can be given a very slow amount of glucose via intravenous administration, but we need to go slow because the kidneys might not be able to get rid of the water fast enough. And we do it slowly so that we avoid the hypertonic hydration. We don't want them to be overhydrated with a really sugary water solution, with a hypertonic sugar water solution. We just want to give them enough sugar water to reduce the amount of protein digestion they do or gluconeogenesis they do to their own bodies. That's all we have for this recording. If you have any questions or comments, please feel free to post them in the class discussion boards or to shoot me an email. And as always, happy studies.